Thank you. I'll let you go now, quick.
Just make sure everybody's in and settled in. So hello everybody, my name's Joel Hannon. I'm NMP lead for Bolton. I'm also a medicines optimization pharmacist. Hopefully you can see the screen that I've got there. Just some common issues about NMP prescribing update. I've tried to put it in a flavour with what was covered during today around, I've put learning difficulties because learning disabilities gets you on a register. Autism is it's an up and coming access onto the registers, so sometimes people can be missed out. So just actually, if anybody does have learning difficulties at all, it's something to consider as part of the prescribing decision. And also, obviously, when you come to children and young people with asthma, again, a really challenging area for what to go through. I'm going to try and cover some basics for you and do it twice as quickly as I was planning to. And if you do have any questions, please ping them in the chat. Even if it's a question for next time, you want something being raised, please fire it in there. Much better if I'm answering what you want to know about rather than what I want to tell you. So feel free to ping any messages in. The first thing with any of these is to go back always. I am a broken record on this one. If you've been to any of the other updates, competency framework for all prescribers. So this does apply to all prescribers, but again, is that challenge for whether you're doing learning disabilities, whether you're doing asthma in children, in adults, whether you're doing anything that you've done for 40 years or for 5 minutes. Are you competent in all areas of this? Is a really, really simple 10-point question to go through. Are you competent to assess the patient? So do you know what's going on with that, to identify the evidence-based treatments? Hopefully that's where you can get support from medicines optimization, from formularies, from areas where they support these things and help you with your choices. So you can update your P formularies, present the options and reach the shared decision. So again, looking at learning disabilities, with this, sharing that decision is incredibly difficult, especially if you've got a communication issue, especially if you're unsure of whether actually that's going to be the long-term plan for the patient. And also you've got a carer who's usually integral to that care. So all of these things come in. It's not as simple as you've had a heart attack, here's your 4 group of medicines that we're going to put you on. Is that okay? It's about that two-way discussion. Being able to prescribe it effectively is number 4. Providing the information, again, when it comes back to if you're talking about the learning disability, and one of the long-term problems with this is how do you get that information across when it's difficult to share information. Monitoring and reviewing with the letter update and also with children and young people with asthma. Monitoring and reviewing process is often missed off of any of the discussions. When do you need that patient back? When do you need to review them? When do they need to call you? Prescribing governance, can you prescribe safely? So slightly mentioned there in the letter review with learning disabilities was the use of antipsychotics. I'll bring up a slide with the STOMP stamp on there, so you've got a bit more information there. Prescribing professionally, again, that covers a multitude. There's 10 points on the framework plan there, but again, it's actually, do you know fully what you're doing? And then improving your prescribing practice, how do you review what you do? And lastly, prescribing as part of a team. You're not an island as a non-medical prescriber. You are part of a network. You are part of a scope of practice. If you are changing medicines or prescribing, key thing is actually, can you fall back on what's within your competency that you've put forwards as your NMP? So with this, you'll be looking at what are my competencies, what am I skilled at, what can I prove that I can do, and is this within my scope of competence? It's easy to review that regularly. Are you doing things that you know that you are evidence-based, or are you doing things because other people have done them, or because you think they're right? If it's getting to the think, you need to go back and know. That is often what's in most guidance. It's that really simple. You can't just, yes, this looks right. You've got to know it as a non-medical prescriber. Really simple when you're working within trusts. NMPs, if it's not on your P formulary, if you're a respiratory nurse on a ward, you're not going to update a patient's laxatives or PPI. That's out of your scope. You're going to pass that on to another member of staff. Same with primary care. Somebody asks you to issue all of their repeat prescriptions. Actually, that's usually never appropriate as part of the review. You'll have a system to direct them through. And if we link this back to medical prescribers, it's no different from GPs. Really, really simple. If a GP, if it gets beyond their competence, they refer into another service. I mean, if you think of cancer treatment, every GP will see hundreds, if not thousands of patients that go on to cancer treatment. They would never, ever consider issuing those medicines themselves. It's knowing where that falls. Again, what can you evidence as a non-medical prescriber? It's done by other professionals in the same way that if you're referred into a consultant, they will never try and sort something out that's beyond what they can do. If it's a urologist, they won't come back and say, by the way, I've started them on some iron because I noticed their full blood count was a bit low. They will pass this back to somebody who knows what they're doing in that case. Just to highlight it, this is a really dreadful spectrum of competence. There's lots out there saying, where do I fit in? Where do you know? It's just an example to say, actually, where do you fit? Your competence does have a start and a finish. That's whether you're a super specialist, that's whether you're a generalist, that's whether you're a practice nurse. Where yours fits in this, where you should be handing off to other areas, where you know more than others, it's always good to basically have that idea, that sense. Again, your competence might increase. Actually, if you go more specialist, you might actually notice your competence, your focus reduces. If you're purely seeing patients for your diabetes review, your knowledge of asthma, your knowledge of hypertension might decline. And it's being aware of that changes over time. And just to try and cover up, because I think we've got about probably 8 minutes left, just some resources there. These slides will be going out, so the links are in there. LD resources, from what was covered earlier, often it's really, really incredibly easy. Unfortunately, there was a national plan around LD where they put it into a quality improvement section of QOF. Unfortunately, that fell during the pandemic. So again, very, very few areas got a chance to actually fully work on that. There is the details there. It's a plan on a page of what was actually being asked. It is a summary from somebody else because the main document is quite huge. So that's the first link there. And also many of the areas that managed to do some work on this before, when they looked at this of getting ahead of the game and doing it in January and February of 2020 rather than waiting, looked at the positive behavioural support. There's a really good website and information there. So if you wanted to think a little bit deeper, think about what you could do to support patients with LD, with autism, with neurodivergent, all comes into this. Actually, how do you stop and think what options are there? Many of the information that they share is about stopping challenging behaviours. And with this, it can be the most detrimental part of this. It can also be the easiest to treat. Many people in the past have decided that antipsychotics reduce people's life expectancy even more. So again, they should be absolutely last point of contact. Your local teams and your specialists should be the ones that are coming in there and looking at every other option that you've got out there. Again, a key thing is if you come across as any of your reviews, anybody who's on your LD register, just know that life expectancy is around about average. The last update that I saw was 14 years less for men and women. So getting down to the age of 59 or 60. Again, part of the plans there, annual health checks is in your QOF. So that's one of the really simplest things to look at, because what causes the shortness of life expectancy is their CVD. Aspiration pneumonia is a really high one. So if somebody doesn't like swallowing tablets, please don't switch them over to liquids. Swallowing problems normally means they've got a functional problem with actually swallowing. Putting liquids means that liquid can easily get into the lungs rather than be more easy to swallow. So you feel better because they're not struggling so much to swallow. Unfortunately, that liquid can get into the lungs and cause problems. Same with their drinking, same with eating. So do think swallowing difficulties, don't always think it's because it's a tablet and they don't like it. Always do think, is there something functional happening with the swallow? You've got respiratory disease, which is going along with the asthma and the COPD. So again, actually, are they smoking? Are they in an area which is other people are smoking? Actually talking, taking that opportunity for that annual health check to look into that. And seizures, again, taking the medication, being supported. But one of the main things when you look for the reasons why people die early on LD often is because of the lack of communication they're able to make. And so part of this is understanding that, but making sure that everything that you can do around that, you're looking for those signs of the cardiovascular disease when you're doing those reviews. You're making sure that they do turn up. you're asking the carer why they can't come into practice, and often taking the lead from the carer. Working in COVID vaccination clinics, I saw some superb ways round of engaging with people, getting people in, getting people away from noisy, difficult areas. But all the ones that worked really well, it was the carer, it was the parent, it was the person that was coming in with them, was able to say, this is how they can cope. A great one where somebody, they could have an injection as long as they were watching a video about Father Christmas. And so they said, as long as they're in a quietened corner and they're able to just watch that and not see the needle, they could have the injection, no problem at all. And that was absolutely spot on. You know, so taking the lead of the carer to know actually how do you engage with that, whether it's an appointment first thing in the morning, whether it's an appointment last thing, so it's quieter. All of these things are things you can consider, but do engage with the carer. There's nothing worse than saying, I've set up this whole new system for you because you're different and it's not being right for them, or you've thought that it would be helpful when it's not. It was talked about in the presentation where people don't like labels, people don't like being treated differently. Ask them first is always a great way of looking at it. And as I said, a bit more about STOMP and STAMP. So STOMP, if you do find anybody that's on your LD register or that's autistic, that's on antipsychotics, please stop and think about 17 times about this. We do know it shortens life expectancy. We do know that they can be used if there's psychosis for the patient, then that needs to be treated. That may be absolutely appropriate. But it's stopping and checking, going, has everything else been done to avoid using this medicine if we can do? Are the specialists involved? Are the teams supporting? Have we exhausted everything that we can do? Because we know already we're reducing life expectancy in this population. If you add in antipsychotics that aren't clinically and evidence-based to basically make people either more able to be dealt with, all of those things shorten their life further. So there's other options out there that your specialists can help you with. And STAMP, again, similar to this, is looking at those positive behavioural support and other therapeutic support to try and deal with that, trying to engage them, not only just with day-to-day practices, but how they get their medicines and how they're supported along those lines. Again, apologies for speaking too quickly. I've had no questions, so I'll nip on to asthma management. And with this, I put this up. This is probably teaching grandmothers to suck eggs here, so I do apologise. But when you're looking at prescribing around asthma or any areas, please do go back. What's the main source of the evidence that I've got here? I've just put here, it's a nice shortened view from CKS NICE. So the NICE guidance, well worth a read. If you're doing a specialty in this area, do have a look through the 90 odd pages. Believe me, it doesn't take too long to read through and you do get a lot of information. With this, make sure that your patients are aware that this is what good asthma looks like, whether they're children or adult. I come across too many people who have daytime symptoms, who have asthma attacks, who think it's fine because their blue inhaler saves them. Actually moving that along and having that discussion to say, you should be having no symptoms whatsoever is the ideal. That's where you're moving on to. The information's there, whether it's adults or for children. And again, if you're looking for some really, really good information to make sure that you can apply your knowledge and you know what products are out there, Right Breathe is a really, really good resource. The pediatric guidance that it has is the 2019 BTS sign guidance. It does it in two formats, which is on the left-hand side of the screen. You've got either interactive or you've got reference. The reference shows you the stepwise treatment, but also on there, you've got the prescribing information. So with this, you can actually go in, click on the prescribing options, and it gives you all the inhalers that fall into that area. So when you're looking either building your PEEF formulary or looking at what your options are, when you go to an add-on therapy, actually, what do you mean by this? It steps you into there, gives you an example, and the screen that appears is the one on the left-hand side. You can choose whether it's pediatric asthma license, adolescent asthma license, and then it comes up with the information. So there's 42 inhalers here that have asthma and children's information. So if you follow the Right Breathe link, you've got that. Again, make sure, thinking about your annual declaration for your NMP, make sure you can evidence your competencies. Really, really useful if you can say, this is the training setup that I went on, this is what it helped me do. Make sure your learning's completed. Prescribing practices in line with competencies and evidence. So if you're doing this and you're prescribing something not on the list, do stop and think, using that wider information. Make sure you plan your updates. What do I need to learn this year to keep up to date so my